Good morning, everyone. Welcome. Glad to see you all here. I'd like to take a moment and introduce our speaker for you today. It's Dr. Deborah Holder. She is an epileptologist at the Neurology Institute of Children's Hospital, Los Angeles, and she is also the director of the Epilepsy Fellowship. So please, let's give a warm welcome to Dr. Holder.
All right, we're going to talk about EEG and epilepsy. So, and if there's questions as I go, just feel free to ask. There's a lot of talks going on, and this was a topic that hadn't been covered, so that's what they asked me to talk about. So, everyone can hear me okay without the microphone? Yeah, I have the big voice. If not, move closer, because there's lots of empty chairs up front. All right. So I start every talk I give with this slide, which for you all, living in the world of epilepsy, like those of us who take care of kiddos with epilepsy, I'm a pediatrician at heart, so everything I say I'm going to use kiddos because I take care of kiddos, but everything applies to adults as well. So no fear there. I like to set a framework for the need and the abundance of epilepsy that we see in the community. These numbers may be familiar to those of you who kind of live in the world of epilepsy with us providers. So 1 in 26 Americans has epilepsy. This leaves about 3.5 million people in the U.S. It's about 65 million people worldwide. So people are not alone if you have a family member or a child with epilepsy. 1 in 10 people will have a seizure in their lifetime, so we don't have the same number of people who have a seizure as those who have epilepsy. So remember, we use the term epilepsy to mean someone who's had more than one seizure. So you can have one seizure and not go on to have epilepsy, and then if you have more than one seizure, then those are the people who have epilepsy. There's more than 200,000 new cases of epilepsy diagnosed every year, so this is ongoing, adding to those numbers. And unfortunately, about 50,000 people suffer a death related to epilepsy every year. So this is a huge problem. The reason that number is not concrete is we have a real problem with tracking this. So there are a lot of people who don't know that a death was related to epilepsy, either because of someone passing from what we call sudden unexpected death in epilepsy, and the people who are tracking the deaths don't know about that entity, or having other problems that the deaths are attributed to. This is especially in patients that are older, where they may find something like, our coronary artery disease, and they may say, oh, it's from that, it's not from the epilepsy, when it may actually be from the epilepsy. So something we have to keep in mind. And then interestingly, epilepsy is more common than multiple sclerosis, cerebral palsy, muscular dystrophy, and Parkinson's combined. Which is, when you kind of think about that a moment in your brain, you think about how much publicity or press or marketing goes around those diseases, mostly because they have a very public, usually celebrity, talking about their disease, which we're still lacking in epilepsy, right? So we still have a pretty big stigma attached to our disease, and it's very difficult to get people to talk about it. And not because it's a perceived stigma, there's still a very real stigma. So people still lose their jobs, they still don't get promoted to their jobs. I have kids who get kicked out of daycare regularly because they've dared to have a seizure at daycare, like they could do something to avoid that. So it's a real problem. What we still need to do is education. The only way really to get around this is to educate people so they understand epilepsy better. So it's something we're all working on. And then we know if you've been on 2 treatments for your seizures, the likelihood a third medication treatment is going to work is actually less than 10%. And that number's actually been repeated in numerous studies over the last 30 years. So 30 years ago, we had about 5 medications, and if 2 medications didn't work, the likelihood a third will work was under 10%, and we repeated those studies in the early 2020s, and the number didn't change. So despite 25 medications available now, so you'll see some of the companies that have new medications out, and they're going to say, our new medication is better. It may be better tolerated, but as far as being efficacious, the studies would tell you that it's really not that much more efficacious. So people do better on these new medications because they feel better, but as far as getting this kind of drug-resistant or intractable population out of that category of being drug-resistant, the new medications don't make a big dent in that. As far as looking at the studies, there's going to be a few patients who are going to do better on these new medications, but this 30 to 35% of what we call drug-resistant epilepsy, that number hasn't changed since the 70s. So we really haven't made much impact on that with all those new drugs. So if you or your family member has epilepsy and you've failed 2 medications, you really need to see a specialist. And I would say there's lots of places, we're lucky here in Los Angeles that we have a lot of big epilepsy centers who have epilepsy specialists, but we know that not everybody has that luxury. If you're living in a place where you're not near an epilepsy center, you need to make the trip to an epilepsy center and see an epilepsy specialist, because there's things we're trained to do that neurologists aren't trained to do. And there's tests we have access to that neurologists don't have access to, and there's treatments we can provide that neurologists can't provide. So that at least once you have to see a specialist and really make sure you have the right diagnosis, the right seizure type, you get the genetic testing, and you get the best treatment options at least offered, because it really can make a difference. So we've changed how we define epilepsy, and this is really relevant when we start looking at EEGs. So we have seizures that come in big categories. I like to tell my patients when I first see them that we think about seizures as being focal, which means they start in one spot in the brain and spread. We have generalized, where it looks like the whole brain's firing at once. And then we have a group that we call unknown. Every category in epilepsy, we have an unknown category, because sometimes the EEG doesn't show anything, and we can't make a differentiation. The patient's just found having what we call a convulsive seizure, where the whole body may be involved, and I don't know if it's focal or generalized. So sometimes we can't figure that out right away. So that's the seizure type. Then when we go from seizure type, we go into the epilepsy type, which is a bigger category. So this looks at not only the seizure, but also what's going on more with the patient. Sometimes you can have multiple seizures within your epilepsy type. So you may have focal seizures and generalized seizures as part of your epilepsy. So not everybody has only one seizure type. And then we have syndromes, which looks at the whole patient. This looks at the epilepsy type, the development, the MRI findings, the genetic testing, and ideally we can give you a name of what's wrong, what's causing all your problems, and then I can find the best treatment. If I know you have a specific genetic disease, I can tell you this is the best treatment for you. So ideally we move from the top, your seizure type, to your epilepsy type, to your syndrome type. And then we try to figure out what the cause is. So is there a structural cause? Is there something wrong with your MRI? Do you have a genetic cause? Do you have an infection? Did you have some infection early in life, or have an infection that caused it? Is there something metabolic? Are the chemicals in your body not working correctly, and we have to fix that? Is there an immune cause? We have a huge number of autoimmune epilepsies now, way more than we ever had. I just recently had a patient that had testing done for autoimmune, and they found something wrong, and they haven't even named it yet. And they said, we found something, and we have no idea what it is because we have no name yet. I said, well, how do I put that in my chart? The unknown autoimmune disease. Like, well, that's the best we have right now. So this field is exploding. We just started an autoimmune epilepsy clinic in CHLA, where I work with an autoimmune epilepsy doctor. And we're doing all this fancy testing, trying to find these autoimmune diseases, and we're treating with immunotherapy, things like steroids and immunoglobulins and some of these kind of fancy autoimmune medications, which are making a huge difference in patients with epilepsy. This is a whole brand new field that didn't exist 10 years ago. Yeah.
So how would you find that? Like what
yeah, so the test, so that's very interesting. It's a good question. So I would say that traditional kind of old, I'm old. I have good Italian genes, so I look younger than I am, but don't be fooled. I've actually been doing this for over 20 years. So old epileptologists, when we have patients where we just can't get their seizures to stop, a lot of us use steroids, because we think of steroids as being a seizure can secondarily make your brain inflamed. So if you have seizure after seizure after seizure after seizure, your brain gets irritated by that. And then the brain has a secondary inflammatory response. So to try to settle things down when kids are having lots of seizures, a lot of us will use steroids because steroids is anti-inflammatory. And that's kind of a short-term fix, but it buys us time to do something more permanent. So if I have a patient having lots of seizures, often we'll give a short course of steroids, 3 to 5 days, to just kind of settle things down and kind of buy me some time till I find a better long-term answer. If the patient responds really well and the seizures are gone, and they're gone for months at a time, I'll say, maybe this is autoimmune, because steroids is an autoimmune drug. So in those patients, that kind of sends my brain going, ooh, maybe I'm onto something. So then we look for an underlying autoimmune disease. So that's one way. Sometimes when the patient presents, if the patient presents with an explosive onset of epilepsy and what looks like what we call an encephalopathy, where they have an altered mental status, they just come into the hospital really sick, and they have seizures as part of that sickness, we look for an autoimmune disease. So sometimes it's how they presented in the very beginning that tells us this might be autoimmune, and sometimes it's the treatments they respond to. And the test we do to look for autoimmune is a spinal tap. So we need spinal fluid. It's the testing in the spinal fluid where we look for antibodies. What happens in an autoimmune disease is your body makes antibodies against itself, instead of, usually you make antibodies to an infection, but sometimes your body gets confused and makes antibodies against itself. And we can look for these antibodies in the spinal fluid. So it has to be a spinal tap. That's the only way to test for this. And we do that. We now have this autoimmune epilepsy doctor that we had. I think he's done like 4,000 LPs. He can do it in 3 minutes. I mean, he's superstar. We put all the kids to sleep, obviously, in pediatrics. And adults, they do it while you're awake. It's no big deal. And for any woman who's had a baby, it's like getting an epidural. Same kind of idea. But for kids, we put them to sleep. So you do the spinal tap. We do all these fancy tests. We look for the disease. And then we treat usually first with steroids to see if it works if you haven't already had that. And then if steroids work, the problem with steroids are you can't take steroids forever, right? It's just not a safe medicine to be on the rest of your life. We often do little pulses. We'll give you a little course of steroids for a couple of days, once a month for a few months, and see how the kiddos respond. If that works, then we have a whole group of what we call steroid-sparing medications that we can use that mimic steroids without the side effects. So that's a whole new field of neurology now that we're using in our patients. So it's really interesting. It's whole new. Like I have all these patients that I've used steroids for in years who have responded, and now that we have all this autoimmune testing, now we're backwards going back and testing those patients that we just called steroid responders. So yeah, we get smarter every year. It's totally cool. And then of course we have unknown. We put unknown everywhere because there's still a lot we don't know. We've luckily been able to fill in a lot of these categories with more knowledge as we get smarter. So this is kind of there's a group called the International League Against Epilepsy. They kind of dictate how we practice medicine in epilepsy. Every couple of years they get together and meet and they change names and reorganize everything. So people who kind of follow the world of epilepsy, this is what you see. This is the current kind of organization we use. So it's always good that you're on the same page as your doctors, that you're using the same names of seizures as the doctors are using so that you can communicate good. So we used to use petit mal and grand mal. We haven't used those words for 20 years. So it's important that what name you're using for your seizures is what the doctors are using, is what the school nurse is using, is what your babysitters are using, so that we're all on the same page. So that when you say your child's having little seizures, the doctor knows what you mean. So we can all count things the same and we can all treat things the same. So these are kind of what we do. So these are the new names of the seizures. So we used to use, for people who have been doing this for a long time, we used to use in focal, now remember focal, start in one spot in the brain. So we have focal seizures, we have generalized seizures. Under focal seizures, for people who have been doing this for a while, we used to have complex partial and simple partial. So a complex partial was one where there was a change in consciousness. The person's kind of confused, they can't talk, they can't communicate, they're not completely there. A simple partial was where they were completely there. They can talk, they can communicate, and maybe just their hand is twitching. And they'd say, look, my hand's twitching, but they're otherwise completely there. We got rid of those names. Now we call them aware and impaired awareness. So maybe even easier to understand. If you're aware, you're aware. You're aware, you're completely alert, you can talk, but you just have some twitching. Or you have a funny feeling in your body that you can't fully explain, but the person's completely aware. So this is now called a focal aware seizure. Then there's focal impaired awareness, where you're kind of confused, you can't talk. You maybe have some feeling of what's going on, but you're not completely there. So that's a focal impaired awareness. And there's hundreds of types of seizures in each category. But the main difference is if you're aware or not aware. And then we have motor and non-motor, and that's pretty self-explanatory. If there's a motor component, that's a motor seizure. If there's no motor component, the patient's just sitting kind of confused, but not physically moving anything, that's a non-motor. And any of those seizures can then secondarily become a generalized convulsive seizure, where the patient has convulsive whole body movements. Now sometimes all you see is the convulsive part, right? You maybe find your child in the middle of the night having whole body shaking. Now, we don't know what happened. Did that start with whole body shaking, or did it start focal and then spread? And that's what we have to try to figure out. And then the generalized seizures, we have generalized motor, which can be whole body shaking. It can be whole body stiffening. It can be stiffening then shaking. It can be any combination of that. And then we have generalized non-motor. So these are the absence seizures, where the patient just stares, sometimes staring with eye fluttering. Now, how do you differentiate between a focal staring and the generalized staring? Patient's just staring. How do you know if it's focal or generalized? EEG. We're going to look, and then you'll be able to see. And then unknown. All right, so let's move on to EEG. So when a patient comes in and they say to me, well, I found my child in bed, the whole body was shaking. Well, how do I know what that was? How do I know if that's focal or generalized? So there's sometimes we can ask questions. I can say to the child, did you feel anything before your mom came and found you in bed? And sometimes they'll say, oh, I had a funny feeling in my body, or I felt like something bad was going to happen. Or sometimes the parents will say during the daytime seizures, they come and find me, and then they fall to the ground and have their seizure. Well, that makes me think the child felt something. Even if the child can't tell me, if they come and find their parent, they probably had a feeling something was going to happen. So that would make me think this is a focal seizure, because something happened before the whole body got involved. Or after the seizure, if they have weakness on one side of their body. If the left side of the body is really weak, if the parents say, I thought they had a stroke because one side was weak, that would tell me it was a focal seizure. Now, if they don't get any information, then I'm stuck. I don't know which it is. So then we move to EEG. EEG can be the most useful test in helping me figure out what's going on in the brain. So everybody who has had a seizure should have an EEG. The downside is if you have a routine EEG, like a 40-minute study, about 50% of patients who have confirmed to have a seizure. So they have the seizure that I've seen, and I say, yes, I'm about 80% watching videos. Everybody brings their videos in and shows me. I think me and my team were about 80% watching a video saying, for sure seizure, for sure not seizure. The other 20% can't tell just by video. So if you for sure that's a seizure, only 50% of patients have an abnormal routine EEG. So not great odds, but pretty good. So what can you do to make that better? Get a longer EEG. 24-hour video EEG is going to increase that into the 90s. So if you've had a routine EEG and your doctor can't figure out what's going on, you need a longer EEG. So this is what we do. So people who have had EEG, this is a diagram of the head. The nose is up top. Let's see if I got my arrow. So here's the nose, and these are the ears. A1 and A2 are the ears. And these are all the stickers we put on your head. This is looking from the head down. So the Z's, it's probably easier if I just point. The Z's here go right down the middle of your head for orientation. And then the way it works is the odd numbers are on the left side of the brain over there, and the even numbers are on the right side of the brain. So you see these two here, FP1 and FP2, sit on your forehead. Oh gosh, my hair's falling out. Okay, so they sit on your forehead, and then these electrodes here on the right side go around the right, down by your ear. These are going to be the temporal electrodes. So we have 4 lobes of our brain. You have the frontal lobe in the front, parietal lobe on the side, occipital lobe in the back, and the temporal lobe sits down by your ear. So these electrodes monitor the temporal lobe. The central is right over the motor strip. This is parietal lobe, and these two are the occipital lobe. They sit in the very back of the brain. So the brain is symmetric. The two sides should be similar. So these ones on the temporal lobe on the right are exactly like these, the temporal lobe on the left. And then these come down across the top of the head, covering the motor strip on the right, and these are the motor strip on the left. And then these go right down the middle. So the way that we look at EEG, the EEG looks at the electrical activity of your brain. So we're monitoring all the electrical activity. A seizure is abnormal electrical activity, right? So this makes sense. If we're going to see abnormal electrical activity, the EEG is going to tell us that. So when we look at an EEG, what we're going to look for is we all have normal electrical patterns in our brain. When you're awake and you're sitting there calmly, not doing anything, your brain makes a normal pattern. When you close your eyes, we see a normal pattern that tells me your eyes are closed. I can tell on your EEG if your eyes are open or closed. When you start to get drowsy, I see different waves in your brain as you get drowsy. When you go into early sleep, I see different brain waves. When you go into deeper sleep, slow wave sleep, I see different brain patterns. When you go into REM sleep, I see different patterns. When you're suddenly aroused, I see an arousal pattern. So when you get drowsy, I see a different pattern. So I can tell most everything you're doing just by looking at your brainwaves, without anyone telling me anything. Just by looking at your brainwaves, I can tell if you're awake. Now, I can't tell what you're dreaming, so don't worry. But I can tell if you're awake. I can tell if you're drowsy. I can tell if you're asleep. We can do things to try to make you have abnormal brainwaves, to make you have a seizure. Things that we call activations. So you can tell if you've ever been in a lab where someone has an EEG. We flash lights, and we have you breathe. So those are things that we know induce seizure activity. When we flash lights in front of your eyes, we can see your brainwaves change because of those flashing lights. When you breathe deeply, it makes your EEG change. So I can tell all these things going on. So what we do when we look at an EEG is first we look for all those normal patterns. So it's good if the brain is making normal patterns. That's the first thing we look for. If you're not making normal patterns, that's a problem. That means there's something globally wrong with the brain. Usually somebody with developmental disabilities or intellectual disabilities, that's going to be something we're going to be concerned about. Or somebody who stayed up late because we ask you to sleep deprive your patient or your child, and they need to take a nap, they're a little too sleepy. So sometimes it's only a sign that they stayed up too late and they haven't fallen asleep yet. Then we want to see if there's any abnormal patterns. So there's a lot of abnormal ways we're looking for as well. So we look for normal patterns, then abnormal patterns. We do that from all these electrodes. So the way it works is you have to have electrical activity, and to get the electrical activity, we do it by comparing one electrode to another. So often we'll hook electrodes to each other, and we look to see the activity between one electrode and the other electrode. And by convention in EEG, depending on which electrode is more negative, the wave on the EEG is either going to go up or down. That's just the way EEG is kind of conventionally worked. So when we look at these electrodes on the paper, we use what's called montages. A montage is just how the electrodes are arranged on the page. And there's about 50 different ones we can look at. This is the most common one. The most common one is we link this electrode to this electrode, then this one to this one, then this one to this one, and we make these in little groups of 4. So we have one group of 4 that's this row. Then we have another group of 4 the same on the left. And then we link these together. And then we link these together. And then we link the middle ones together. Now we call this montage the double banana. You can see why, because it looks like two bananas. This is the most common one reviewed on. All the EEGs I'm going to show you are going to be looking this way. So you're going to see groups of 4 electrodes. These first 4 are going to be a row, and then those 4, and then it's going to be left and right. So all we really need to do is see if the left and right are the same. And if anything stands out that's different, then we know there's something abnormal. So this is the one that's most useful and the most commonly used. It's not really a fancy name, but you can see how I got it. It just happened that my highlighter on my PowerPoint was yellow, but it kind of worked nice, right? It looks like double banana. I draw this all the time on the board and when I give lectures to residents, but I like it in the yellow highlight. I don't think I have yellow highlighter or white on wipe off markers, huh? But I can't do this on the white on wipe off board. All right. So we're going to look for abnormalities. We're going to look for differences between the two sides, something we call asymmetry, and we're going to look for all these abnormal waves. And we're going to see if things are focal or generalized. Because remember, focal seizures would have focal abnormalities. Generalized seizures would have generalized abnormalities. Okay, it's easier to look in pictures. So we have waves that we call spikes. So you probably have heard or maybe seen EEG reports that talk about spikes. This is a spike. On EEG, it's less than 70 milliseconds. So the doctor who trained me in EEG said a spike is anything that if you sat on it, it would hurt. So you can see that. It's pointy. If you sat on this, it would hurt. Well, that's how the doctor trained me. I've remembered that for years. I don't remember very much of what I was taught, but that I remember. I was trained by a doctor who used very visual teaching, and you'll see some other things. Okay, this is a sharp wave. A sharp wave is longer than 70 milliseconds. It's more rounded, right? This wouldn't hurt so bad if you sat on it because it's more rounded. So a sharp wave is, in the scheme of epilepsy, a spike usually indicates that the person has a tendency to have seizures. It's bad. A sharp wave is not so bad. It's more benign, right? So a spike is pointy, bad, it's like a tack. You'd sit on it, it would hurt. A sharp wave is rounded. It's not as bad. When we see sharp waves, we're like, not so bad. Spike, we're like, oh, that's worrisome. A slow wave, this is a slow wave. It's a big, like a mountain. It usually comes after a spike. Like here you see a spike and then a slow wave. Sharp wave, then a slow wave. This is just a slow wave. Slow waves sometimes we see when the brain's been injured. So if you have a tumor in your brain and it's taking up space, we're going to see slow waves because you don't have brain tissue there. So sometimes a slow wave can mean something else. Spikes usually indicate someone's prone to have seizures. All right, so these are some examples. These are sharp waves. These are spikes. You see how pointy they are? This is a spike and slow wave. And sometimes the brain gets really angry and it makes what we call polyspikes. So a polyspike is where it goes up and down more than once. So up and down, poly, more than one. So those are polyspikes, up and down, up and down. Usually that's even a little more concerning than just one spike because there's a whole group of them. And there are some epilepsies that we know have polyspikes. Now, not always is the epilepsy bad if there's polyspikes, but it's something that we sometimes worry about. So those are the things we're going to look for when we start looking at our EEGs. Now, what we're trying to decide is if a wave is epileptic or non-epileptic. And what we do is we're going to be looking at electrodes that are paired together. So here we have 2 electrodes paired together, FP1, F7, those are on the left side, and then F7, T3, that's temporal, and then T3 to T5. Now you see these points go together. When points go together like that, that tells us it's actually a wave that looks like this. That's a negative wave. It's a wave that's really a pointy wave, but because the electrodes are going together, when those points go together like that, it actually indicates this type of wave, a tall pointy wave. But the electrodes are, because we're looking at electrodes together, that when you see points like that, that's actually, on EEG, it's this type of a wave. If the points go away from each other, it's what's called a positive wave. That's the wave that would go down, and that's not epileptic. These are benign. So what we're going to be looking for is waves like this, where the points go together, and that indicates a wave like this. That indicates a spike. And it's just the convention of reading EEGs. All right, let's look at an EEG. This is an EEG. So this is what EEG, has anyone seen an EEG? Has anyone had their doctor show them their EEG? I show my patients their EEGs all the time. Because I think it's visual. I think it's really important. I think it helps when you see that. So this is the EEG. So you see little, and everybody reads EEGs differently. So your doctor may not have shown you one that looks the way I read, because we all do things differently. Some use red and green to show different colors, and I like everything in black. So it's just the way I read, but it's all the same. So I like little groups of 4 because it helps my brain. I'm very visual, and I like it the same. I like having that space in between. So this is left temporal, right temporal, and then this is left motor, right motor, and these are the Z's down at the bottom. We put the heart down here, but I'm not a heart doctor, so I don't look at it much. But it's there in case we want to see it. Every now and then we look at it, but it's there. And then these are actually eye leads. So your eye actually has a dipole in it, and I can tell what your eye's doing by looking down here at the blue eye leads. So this is the normal pattern. So when you look at an EEG, each group of 4, when you look at these brain waves, the waves in the front of your brain are always short and fast. So if you see here at the top, the waves are short and they're really fast. As you go from front to back, the waves get taller and slower. Now, each of these dark green lines is 1 second. So this whole page is 1, 2, 3, 4, 5, 6, 7, 8 seconds. So you see in each of these seconds, if you look here at the top, it's really fast. There's little fast scribbles, but down here at the back, it's much slower. Right? So everyone appreciate that. At the front, it's short and fast, and by the back, it's tall and slow. Now, this patient has their eyes closed, and I know that because this rhythm in the back of the brain, right here, this nice sinusoidal rhythm that we can actually count. 1, 2, 3, 4, 5, 6, 7, 8, 9. So there's 9 waves in 1 second. That's a normal rhythm you get when you close your eyes. We call it the posterior dominant rhythm. And everybody has that once you get to be about 5 months old. So that's something we look for. It should be 8 by the time you're 8 years old. Most adults, it's between 10 to 12. If you don't have that rhythm at a certain rate, at a certain age, it's abnormal. And we're going to read your EEG as abnormal. So that's something we look for. That's why when you're in the EEG, we tell you to open and close your eyes. And if the child doesn't understand to open and close their eyes, the techs come over and close your eyes for them. That's what we're looking for. You see right here, they open their eyes and it goes away. So this is a normal, we call it the posterior dominant rhythm, something that we're looking for. All right, oh, there's the arrow. See, I was afraid I wouldn't have a pointer, so I put arrows in. I forgot I put arrows in. And nice purple arrows because, let's see, awareness month. All right, so now what we do is we flash lights. We flash lights because it induces seizures in some patients. But the other thing that happens when you flash lights is the back of your brain, your vision cortex goes, oh, there's a light flashing. I like that. I'm going to go with it. And it actually synchronizes with the flashing light. And that rhythm we just looked at actually speeds up to match the flashing light. Totally cool how smart your brain is, right? So down here you see these little red hash marks. That's the rhythm of the flashing light. And if you see right here, that back rhythm actually sped up to match the flashing light. Totally cool, right? So fun what your brain does. Who knew, right? You had no idea that was happening. We call that photic driving. It's completely normal. It doesn't mean anything. It's just a fun thing we get to see when we read EEGs. And if we watch, as this gets faster, that's going to get faster. So that was at 7 hertz. Now we've moved up to 13 hertz. See how it's faster? The lines are faster and the rate's faster. And then we move up to 17 hertz and see how it's even faster? Totally cool, right? Okay, fun with EEG. All right, so now we have hyperventilation. So we have you breathe. Breathing, does anyone know what kind of seizures breathing induces when you breathe deep like that? So absence seizures. So the staring seizures that kids have, these staring brief seizures, if you breathe fast, we have them. Kids come to clinic and we're asked to rule out absence seizures. We'll have them breathe in clinic and we can almost always induce someone to have a staring seizure. So other seizures are induced by hyperventilation, mostly the generalized seizures, although occasionally a focal seizure, but it's a very easy way to induce seizures. This is why sometimes kids have seizures when they exercise or they're running around playing. It's that hyperventilation. So we do this in almost every EEG. But when you breathe in and out, you know how you get a little lightheaded and you feel a little fuzzy? Your brain waves actually change. It makes your brain waves slow. So you remember what the normal EEG looked like. Now you see all these big slow waves. Remember we looked at slow waves. Those are the fat like mountain waves. You see them everywhere, generalized. The whole page changes, all these slow waves. Completely normal, just someone hyperventilating. This is the same thing that happens when your EEG gets drowsy. You see the same slowing. So sometimes we have to figure out, are the patient hyperventilating? Or we also see this when someone's crying, because you hyperventilate when you cry. So if we're hooking up a little tiny child who doesn't like being hooked up and they cry and cry and cry and cry, this is what we see on their EEG. So you have to have a little bit of context. So our techs will often write messages to us on the EEG to let us know what they're doing. Completely normal, this high amplitude slowing. Some people who don't know how to read EEGs might think this is a seizure because it looks so abnormal. It's not, just normal. All this slowing, completely normal for hyperventilation. All right, now this patient's asleep. This looks completely different than our awake EEG. These kind of pointy waves, you'd look at that and say, oh, those are spikes. You told me if it's pointy and you sat on it, it would hurt. Those are spikes. These are normal waves that we see in sleep that look like spikes. We see these predominantly in children. In children, they're very high amplitude, and we see them here in the middle of the brain. So these are our middle of the brain electrodes, and we have all these pointy waves, and they come in long runs like this. We call these vertex waves, because if they're vertex of the brain. Not uncommonly, we get kids referred to us to rule out seizures because an adult neurologist thought these were spikes. Because you don't see these in adults this prominently. So this is the difference between a pediatric and adult EEGs. They look like spikes. They meet the criteria for spikes, but it's a benign normal variant. So this is where you have to really be trained in what you're looking at because it meets the definition of a spike, but it's something that's normally there. This is a normal sleep pattern. They're very high amplitude and they come in these long runs, but it's completely normal. Just tells me the person's asleep. There they are, those normal spikes. All right, so what looks wrong on this EEG? Something looks really wrong, right? The two sides don't look alike. We have left, right, and something looks off. Yeah, we all agree something looks off? So this side looks pretty good. We have our kind of normal differentiates from front to back, but this side, the lines just look flat. Right? So this is asymmetry. So something's wrong with this child's right side of their brain. The lines are just flat. They're not making brain waves. So that's a problem. Something probably pretty significant happened to the entire right side of this child's brain. So the two sides should look the same. Anytime there's a big difference between the right and left side, first you have to figure out which side is abnormal, and then you have to figure out what's wrong. So this is pretty easy because this side looks pretty normal. So this is something significant happened to this side of the brain to make the brain waves flat. That's a pretty significant injury to the right side of the brain for the brain waves not to show any electrical activity. So that's something we have to investigate. All right, now this is also something asymmetric. So this is a different problem, but there's something different between the two sides. Yes? Everybody see a difference between the two sides? So here we have these big slow waves. These are these slow waves that look kind of like the mountain. See? Oh, that's my bad. I should sit on that side. I need my good arm. So here's these big slow waves on the right side. So this is what we call focal slowing. So we see this in tumors. We see this in a focal injury. You can sometimes see this after a stroke. You also see this after a seizure. So think about what happens in a seizure. During a seizure, your brain's really active. Let's say the patient has a focal motor seizure. Their right hand is twitching for 3-4 minutes. The brain's really active. There's a lot of blood flow. The brain cells are crazy active. Then the seizure ends. Now the brain has to recover. It goes to sleep for a little while. Your arm may be weak. This is what your brain looks like after that. The brain waves are slow as the brain recovers. This can last for 30, 40 minutes, sometimes a couple of hours. So when I see this EEG, when someone's come to the hospital and they tell me the patient may have had a seizure, this would tell me that the seizure happened in that area that was slow. So you don't always have to record the seizure to get the information from the EEG. If you do an EEG right after a seizure, you may see the after signs, the postictal signs of the EEG showing you where the seizure occurred. So sometimes even if the seizure ended, it still may be useful to get that EEG because I can see this after seizure slowing. So slowing can be a sign that the brain's still recovering from a seizure. It can be very useful. So focal slowing. Anytime we see slowing on an EEG, if a patient hasn't had a picture of their brain, we always recommend getting a picture because we want to make sure there's not something in the brain that's causing it to be slow. That's the other most common thing that causes EEG to be slow. All right, so here we have our epileptic discharges. Here they are. So these are those brain waves pointing to each other. They're spiky. They look like if you sat on them, they would hurt. This is an indication that this patient probably has focal seizures, and they're coming from the right motor area. So over here, right where the motor strip is. So this patient would probably have left seizures on the left side of the body that would probably make the body twitch. So just by seeing this one page of EEG, I could tell this family that the child probably has seizures. They probably involve the left side, I had the right one. Left side of the, left and right, I get confused. The right side of the brain, left side of the body, they probably involve the left face and the left arm. So this patient probably has a disorder we call self-limited focal epilepsy of childhood, what used to be called benign Rolandic. This is a classic EEG for that. So right-sided discharges. So just one page of EEG, we can learn all that information. There they are. So this is another EEG with the opposite. The discharges are on the left side this time. So exact opposite. So this patient would probably have seizures coming from the right side, the right motor strip. Those discharges are sitting smack dab right in the middle of the patient's motor strip. So this patient with just one EEG, we can tell would probably have seizures coming from the right motor area. Then this is the patient in sleep. So look how many more there are. Covering the whole, you can see all these discharges everywhere, right and left side. So this is classic for the disorder self-limited focal epilepsy of childhood. These kids have what we call sleep activation. So during sleep, the EEG becomes very active. So sometimes people think this is a bad thing, but in some types of pediatric epilepsy, this is very common, and it doesn't mean it's actually bad. It's just something we see in certain types of epilepsy. So we just have to know what we expect to see. But this is very common to have these bilateral discharges that are sleep activated. So when you find that, in some cases, it actually points you in a very kind of benign direction in a type of epilepsy that's actually outgrown, and the kids actually do very well. So not every active EEG is necessarily bad. It may be consistent with a certain type of epilepsy. So that's why it's important to get sleep on your EEGs. All right, so what looks different about this EEG from all the ones we've looked at? Anybody want to guess? Now that you're all EEG experts? Anybody? What looks different? So we see the abnormality here. What looks different than the last one? So it's generalized. Right? The whole page is involved. So all the other abnormalities were focal. right? So these patients have focal seizures. Remember, we talked about focal and generalized. Focal, the seizures start in one area of the brain and spread. Generalized, the whole brain fires at once. So these are focal discharges. Left focal, right focal. Even this one is multifocal. It's focal, but in multiple areas. You see the discharge is just in one spot in the brain. This one, the whole page changes. It's what we call a generalized discharge. So this is the difference between focal seizures and generalized seizures. So if you have the patient having an event where they come and tell me that I found my child in bed and the whole body was shaking and they have this EEG, I'm going to tell them they have generalized seizures. If the whole body was shaking and they have this EEG, they had a focal seizure that's secondarily generalized. They just didn't see the beginning of it. So that's a big difference because you use completely different medications and we do completely different diagnostic workups. This patient needs an MRI to make sure there's not something focal on the brain that may be causing the seizures. This patient doesn't need an MRI because it's a generalized seizure. There shouldn't be something focal in the brain causing a generalized seizure. So a completely different treatment route, completely different diagnostic route, completely different diagnoses, completely different types of epilepsy. So you can see here the whole brain changes at once. It's not focal. So this is a generalized discharge. You see a combination of spikes, of pointy waves, and then a slow wave afterwards. This is what we call a generalized spike and slow wave. The difference is it's generalized. So different type of epilepsy. Here's another generalized spike and wave. So again, the whole page changes. And this is a faster one. So here the waves are smushed together. So they come at different rates. So we count how many discharges there are. These dotted lines are 1 second. We count how many there are. And there can be anywhere from 2 to 3 to 4 to 5 to 6 to 7 spikes in 1 second. And depending on how many there are in 1 second, we can help tell you what type of epilepsy you might have. Because different types of epilepsy have different frequencies of the discharges. There's a different number of spikes per second in different types of epilepsy. So the text here, they're doing photic stimulation. A lot of these generalized discharges are triggered by flashing lights or breathing. And the tech here commented that the patient was still able to follow commands. So they're trying to tell me that there wasn't a change in their thinking during that discharge. So sometimes they are. Sometimes they're actually seizures. Oh, going the wrong way. Okay. So let's look at some seizures. Okay, so here we have a focal seizure. So all those things we looked at already are what we call interictal abnormalities. So in epilepsy, we use the word ictal to mean seizure. We use postictal to mean after seizure. Post is after. And we use interictal to use in between seizures. So you can have abnormalities on your EEG that occur when you're not having a seizure, but tell me you're likely to have a seizure. We call those interictal abnormalities. So they're not seizures, they just tell me your brain is irritable and capable of making seizures. So all those little spikes, the pointy waves, they're not seizures, they just tell me that you or your child is capable of having seizures. So now we're going to look at some actual seizures. So these are actual seizure discharges. So you see here, you have this rhythmic discharge that starts here at C3. That's the electrode that sits right over your motor strip. And it's a nice rhythmic discharge right here in one small place. And it kind of changes. The waves start short and they get taller as we go toward the end of the page. And they get a little faster. So it changes in height and speed as we go from the front to the back. This patient had rhythmic twitching of their right hand when the seizure started. So this was a focal motor seizure that started on the left side of the brain and involved the right side of the body. We don't usually capture these in an EEG lab. This patient was having a routine 40-minute EEG and just happened to have a seizure. Happens occasionally, but not too often. So that's a focal seizure. So it's focal, one spot in the brain, right? Just one electrode here making the seizure. So it's just a focal seizure. All right, this is another in-between seizure discharge. These discharges are here in the back of the brain. Where's my mouse? So here, these are on the back of the brain in the occipital. You see these little pointy spikes. They're bilateral, both sides of the brain. So this is a patient with occipital seizures. This patient saw visual stigmata. They saw a little band marching into their visual stigmata. It was a happy visual stigmata, so it didn't bother the kiddo. Now, what do we think about this discharge? Generalized or focal? Generalized. You're so smart. So this is a patient with absence seizures. So absence seizures are short, generalized seizures where the patient stares. Sometimes they have eye fluttering. If we counted how many of these spikes there were per second, there's 3. So this is a classic discharge with 3 spikes per second, and when their eyes flutter, they flutter 3 times per second. You can actually count the eye fluttering exactly in rhythm with each of those spikes if you look closely at the patients. These seizures are short, usually 4 to 6 seconds, and often the patients will start to stare, they'll have the seizure, and then when the seizure ends, they can finish their sentence. They're that short, and they come on and go away that fast, just like someone flips a light switch. The seizure starts, the child stares for a few seconds, and they come right back. This is a disease primarily of pediatrics. We don't see these that often in adults. And you can see the EEG is normal right before it starts. The seizure starts, and then as soon as it ends, the EEG goes right back to being normal. There's not usually a postictal period with these seizures. And they're very classic. This is a pattern that most every neurologist sees this pattern. They know exactly this is an absence seizure. It always looks exactly like this. You have these very clear spikes, and you have a very clear slow wave afterward. And it's always 3 per second. It's a classic EEG pattern. Absence seizure. This is the one that we can induce by hyperventilation. These kids really don't even need an EEG. They come to our clinic, they have staring spells. We usually use a paper towel in the lab. They use a little pinwheel that they have them blow on. You have them blow for a minute or two. They stop blowing, they stare, sometimes their eyes, and the parents go, that's it, that's what they do. Like, okay, absence seizures. Send them on their way. These seizures almost 100% go away, usually within a year or two. So it's one of our easiest to treat self-limited epilepsy syndromes. So it's a pretty classic kind of pediatric syndrome. All right, this is a patient having what we call myoclonic jerks. What time am I done? Okay, you came in, you scared me.
And I follow you, so you can...
Okay, no, I thought, no worries. Okay, this is a myoclonic jerk. Does anybody know what a myoclonic jerk is? Has anyone seen that type of seizure? This is an unusual type that a lot of patients don't know about, and a lot of doctors actually don't know about. This is a quick little jerk of your body. So when you're falling asleep, has anyone ever had a jerk when you're falling asleep that kind of startles you? That's a myoclonic jerk. Don't worry, it's not a seizure. That's a benign myoclonic jerk. We call that sleep myoclonus. Everybody does that. So every time I teach about myoclonic jerks, I get lots of calls. I'm having those myoclonic jerks. You're not. That's normal. But you can have that associated with an abnormal discharge, and that can be an epileptic myoclonic jerk. So what usually people report is that their child is clumsy because they see them drop things. So they have these little quick jerks where they drop whatever they're holding. They usually occur first thing in the morning, and the things that are dropped are usually the shampoo because they're taking a shower, or their breakfast, whatever they're eating for breakfast, their orange juice, or if they're older, their coffee or tea. And it's a quick little jerk that often you don't see, you just see the results of it. You see whatever they dropped fall onto the floor. So if you're not watching them closely, you don't see it. And the people who have it say it feels like either a muscle spasm or a little electric shock. So this is what the EEG does. This is another generalized discharge. So you see, just like we saw with the last one, the whole page changes. These discharges are squished together. It's a little faster. So this is what happens during the myoclonic jerk, this little discharge right here. So we have a type of epilepsy called juvenile myoclonic epilepsy, which occurs in teenagers, that this is a hallmark seizure type of. But we always have to ask, because I've never had a teenager come in and say, boy, my myoclonus is really bothering me. So this is something that no one knows about. I had a teenager that I followed who had generalized tonic-clonic seizures. They were on vacation and they were all sleeping in one hotel room, and they found the child having a seizure in the middle of the night. And when I saw her in clinic, she had an EEG that looked like this, and I asked her if she'd ever had jerks, where she ever dropped things or felt like her body was jerking. These are very commonly induced by photic. These patients are very sensitive to flashing lights. And she said, only when I go out in the sun, like everybody else. And her mom said, what are you talking about? Nobody has twitches when they go out in the sun. And she's like, oh, I thought everybody did. So she thought that was just normal because it had been happening to her for as long as she could remember. And she didn't even know that was something abnormal to tell anybody about. So this is something you always have to ask about. So as physicians, we always ask patients who have these kind of EEGs if you've ever dropped something or feel like your body's twitching and you can't control it. And so we have to really dig for this because nobody comes in complaining about it. But it's a very easy EEG to see and to read. These are drop seizures. So these are patients who fall headfirst to the ground. These are really scary seizures. I had a patient, I was standing next to a patient who was sitting in the chair in my exam room who had a drop seizure headfirst to the ground. It made my heart stop. I mean, these are really dangerous, scary seizures where they just lose tone and drop. The EEG is very similar. This is another generalized seizure. They have this generalized wave on their EEG and literally just fall headfirst to the ground. They last a second. It's just a quick drop, but they can be, even though they're not long, they can be some of the really scariest seizures. So these are also pretty easy to pick up on EEG.
Is that one they don't show signs before?
They don't have any warning or any prodrome. They just drop. And it's just, you can see how fast it is. So this is a second. This is like half a second, and they're just down to the floor. But it's a generalized seizure type, and these can be very hard. These are the kids that you see that have to wear helmets because they go face first to the ground. And it's only a second that they can be very difficult to treat. And it's almost all, you can sometimes have focal drop seizures, but usually those they just head tilt and one arm twitch, but they're not the ones that go head first to the ground. Usually the head first to the ground are generalized. And they can be very difficult to treat and really scary for everybody, not just the patient and the family. I think scary for all of us. Really very difficult seizures. Okay, this is another generalized seizure, and this is what we call a tonic seizure. So anytime the EEG looks like scribble, which is what this looks like, someone just scribbled on the page, that's almost always a tonic. So tonic is the word we use for stiffening. Clonic is the word we use for jerking. So sometimes the kind of old-fashioned grand mal, or the seizure that we all think about, that is really a tonic-clonic. Most of those patients get stiff first, and then they have the rhythmic jerking. Sometimes you just get stiff. That's a tonic seizure. So you can see here, this looks very different than an EEG we've looked at. It's all just very short, fast, squiggly. This is tonic. Anytime I see this EEG, before I open the video, I know the patient's having a tonic seizure. Classic, this is what it always looks like, this little short scribble. These seizures tend to be short, and often they occur in kids with developmental disabilities. But there's still a seizure type we need to know about. The tonic-clonic, I'm going to show you next. This is tonic-clonic, so it looks very different. These are actually rhythmic spikes. So you can see these are actually these spikes that we saw before, those waves that are pointy. So it's a different pattern. If we look back at the, whoops, not the wrong way. If you look back at the tonic, it's shorter and faster, almost like a scribble. The tonic-clonic is really a series of, oh man, wrong way. Early in the morning is really a series of spikes. So just by looking at the EEG, I can tell what the video is going to look like when I watch the patient. Both generalized seizures, both really convulsive because there's a lot of body movement. So, but you can see very clearly how easy it is on the EEG to tell if the seizure is focal or generalized. Right, so it can be hard to tell looking at the patient, but very easy when we have the EEG involved. The problem is, to get this, I actually have to record an EEG. I have to record a seizure with the EEG electrodes on. That's the hard part, right? So if the patient's only having seizures once a month, that makes it very difficult. If you're having seizures every day, not so hard. But you really need to go to that step of recording your seizures if your medications aren't working, because we need to know what we're treating. Maybe we think we're treating focal seizures, and we're really not. I had a patient that came to me for a second opinion, and her seizures were, she'd walk in a circle, and then she'd have a convulsive seizure. Everybody thought those were focal seizures, because it makes sense. If you're doing something first, that's probably a focal seizure. She had been put on multiple focal drugs and wasn't doing well. We did an EEG, and it turned out it was generalized. That spinning in a circle was a generalized seizure. We put her on a generalized drug, and she's been seizure-free 2 years now. She's getting ready to get her driver's license. So the EEG, and I thought that sounded like a focal seizure. So everybody, they weren't completely wrong. Her routine EEGs were all normal, so there was nothing to help us. So really, it can be quite difficult. All right, this is another pattern that's important to recognize in babies. This is what we call hypsarrhythmia. So there's a baby type of seizures called infantile spasms. It's one of our worst types of epilepsy, and it's a true neurologic emergency. So babies have these little spells where they either extend, and they just have this little quick extension, or they have this little crunch. And they look very benign. It looks like just a little startle. And they do them in clusters. Very bad type of epilepsy. So we like to make sure anybody who sees these little crunches gets the baby to a doctor. This is what their EEG looks like when they're not seizing. So you can see it looks nothing like our routine normal EEG. It looks like chaos. It looks like a child just scribbled on the page with a crayon. So when you see this chaotic, disorganized, tall, scribbly waves, this is what we call hypsarrhythmia. This is a very bad pattern, and it's a very bad type of epilepsy. So the seizures that they have are called infantile spasms, and this is where the seizure occurs. The EEG actually looks more normal during the seizure. So it's a little bit kind of against normal thinking, where the EEGs look worse during the seizure, and this time the EEG looks better during the seizure. So that's a pattern that we really want to keep in mind. All right, and then I want to talk about one other thing. This is what we call electrical status epilepticus asleep. So some people hear this word talked about a lot. This is a pattern we see when kids are asleep, where they have loss of cognitive skills. So they usually have a diagnosis of seizures, and then they have loss of cognitive skills, and when they go into sleep, instead of having nice normal sleep patterns, they have what looks like a continuous seizure. This is the pattern. You see, there's nothing normal about this. These are all these generalized spikes, and they have this pattern continuously when they're sleeping. So instead of having normal sleep patterns where they can cement their memories and learn and develop, their sleep is disrupted by this pattern called electrical status epilepticus asleep. This needs to be treated. If you don't fix this, you don't get your cognitive function back. So anytime a patient has loss of cognitive skills, what you really need is an overnight EEG to make sure this pattern's not there. This is something we can fix. So if there's a child who's developing really normally and then suddenly has a loss of skills, we like to get an overnight EEG to make sure we're not dealing with this. This is something that we can often treat and get back to normal sleep patterns. So it's easy to diagnose. It's very easy to see. It's very abnormal. So that's something we need to look for. All right. I just had a bunch of seizures here, but we'll skip those. All right, questions. Let me see if there's any questions. You're now all expert EEG readers. So when your doctor shows you your EEG, or when you get a lot of medical records now, they dump the EEG report right into your my charts or patient portals, right? You guys have access to that. So now when you see your EEG shows focal spikes or generalized spikes, you'll be able to picture it in your head because you're now all experts. Yeah? Questions? Yes, you can, absolutely. So epilepsy is just that interesting. So in the same EEG, you can have generalized discharges and focal discharges, and you can have both focal seizures and generalized seizures. So we call that mixed epilepsy. Yeah, it's not that easy, right? We'd like life to be easy and people to just follow the rules and have just one thing wrong, but not the case. And that makes it hard, right? So we have drugs that treat focal seizures and make generalized seizures worse, and we have drugs that treat generalized seizures and don't work for focal seizures, and then we have the treat everything drugs, what we call broad spectrum. So if you're not sure what's wrong with your patient, you use the broad spectrum drugs, because you never want to make anybody worse. And if you have a mixed epilepsy, you have to use the broad spectrum drugs, because we don't want to make anything worse. The worst thing you can do is have somebody with generalized seizures and put them on the focal drug, because you're going to make them worse. So we don't want to do that. So you have to be really careful. And then you don't want to use the focal drugs are things like oxcarbazepine, carbamazepine, tegretol, trileptal, Dilantin is a focal drug. Some of the newer drugs, Aptium is primarily a focal drug. Vimpat is primarily a focal drug, lacosamide, but probably works okay for some generalized seizures. So the drugs that we call sodium channel drugs are kind of the focal drugs. And if you have a true generalized epilepsy and you get put on a focal drug, it can actually make your seizures worse instead of better. Sometimes it can actually put you in a status epilepticus. It can be really quite dangerous. So we try to be really careful as providers when we see somebody where the EEG is normal or it doesn't give us a good answer and we don't have a good, clear story of focal seizures to use kind of one of the broad spectrum drugs. Broad spectrum drugs are things like levetiracetam or Keppra, valproic acid or Depakote. Lamictal or lamotrigine is generally broad spectrum. We have a whole bunch. What else? Onfi is broad spectrum. Clobazam. Off the top of my head. What else?
Depakote?
I said Depakote. Yeah, no, good answer. Good answer from Dr. Billette in the back of the room, helping me out. There's a whole bunch of... Banzel is usually broad spectrum. Banzel has some sodium channel activity in it, as does lamotrigine. So for kids specifically with SCN1A, where you really can't use sodium channel drugs, we generally don't use those. But for typical generalized epilepsy, they're usually okay. So it depends on exactly what we're treating. But just for our ordinary generalized epilepsy, they do generally okay with Banzel and lamotrigine. Yeah. Yeah, Epidiolex, thank you. Good answer from the room. Epidiolex is broad spectrum. Yes, absolutely. Yes? Yeah.
Went on to generalize
Yeah.
in conjunction with neurons.
Yeah. Yeah, so it doesn't. So it's interesting. So while the focal drugs, in epilepsy, we generally think, I shouldn't use generally because I'm talking about seizures, we often think that the focal drugs work better for focal seizures, but not for everybody. And I think the final answer is going to be in genetics. So I think probably what we're going to learn is if you don't have a structural abnormality and you don't have kind of autoimmune, that probably everybody else is going to fall eventually into genetics. We don't have an genetic answer for everybody right now. I think in drug-resistant epilepsy, that number is going to be pretty high. Maybe even as high as 70% with the genetic answer. And I think that drug is going to be related to the genetic disease once we find them all. We don't have them all yet. We've got about 400 genes that cause epilepsy that we can identify. And I think what we're finding is that the genetics is more important. So example, we have SCN1A, which I just mentioned, which is Dravet syndrome. Those kids often have focal seizures. That's how they first present, with focal status, one side or the other. But the focal drugs make them worse. So you have to go against what the seizure type is and treat the gene. The gene tells me don't use focal drugs. Use things like Depakote or Epidiolex, or these new ones, Fintempla, and the other new ones that have come out. But there's another gene called SCN8A, which is a gene that those kids have generalized seizures. Their EEG is generalized. Everything, they have those tonic seizures with that low squiggle. But those kids respond to Tegretol, which is a focal drug, which I would never give. I would look at that EEG and I would say, absolutely not, don't ever give that kid Tegretol or Trileptal, oxcarb or carbamazepine. It would make them worse. Yet you give that child low-dose Tegretol, cures them. Seizures gone, movement disorder gone, they're like cured, which I would never do. So genetics wins. Genetics always wins. It goes against everything I was taught in school. I have to throw out the window. Genetics always wins. So my guess is if you respond better to a broad spectrum drug, probably the answer lies in genetics. Even if you don't find anything, we probably just haven't found that gene yet.
And genetics has evolved in the past 10 years.
Oh yeah. Oh, it evolved in the last week. They find, because we do a lot of, we have our own lab at Children's, so I'm spoiled. So we do a lot of gene panels, but if we don't find the gene panel, we do whole exome. We just diagnosed a kid a few weeks ago because there's only 5 kids in the world with his gene. And I just saw a kid that came to see me from England, and there's only 2 in the whole world with his gene. So this is the way genetics is. So the gene panel is definitely where you start because we get about 305 genes on most of the gene panels that are available and no matter what company you use, all the companies do good testing, and they all have about 300 genes. Those are the common ones. If you don't find it in the common genes, then you move to what we call whole exome, which is where they sequence everything, and that gets you every gene that we know that's available right now. But even having said that, you probably have to repeat that in another year or two, because there'll be another 100 that we find in the next year, because there's so many doctors out there doing gene discovery. And I think at the end of the day, once you, and my perfect, I talk a lot about my perfect world, which we're nowhere close to living in. Everybody would get gene testing when they have their first seizure, because then I can be so much smarter. And people say, well, you would have figured that out eventually. Well, no, I never would have put a kid with tonic seizures on Tegretol. I would never do that. I would never have tried that unless I knew they had that gene. And then there's some drugs like quinidine we use for KCNT1. That's not even a seizure drug. Like, I would never have tried that. So there's certain things that we would never do, no matter how smart we are, without the gene. So it's not even true to say we would have gotten there eventually, because we wouldn't. Some things we would have, but most we wouldn't. So everyone should get gene testing as soon as you can. Usually we can't get it covered by insurance, especially in California, until you're in the category we call drug resistant. Now I'm what I call a wiggler. So I'm very good at getting people into what they need. So I can call you drug resistant once I kind of start my second drug, so I can get my testing done pretty quickly, because I'm just kind of a wiggler. So I try to get it done as soon as possible, because it's so helpful. It is life-changing for our patients. So if they let me. Sometimes, yeah, it's hard, But Dr. Millett's a wonderful adult doctor. He's coming next. He's down at Hoag.